isn't it really an issue of system fragmentation that doesn't really permit, it's a system design, a system fragmentation that won't allow us to get to the point that you would like to see us get to.
But that's not the whole story, right?
No,
so
it's part of
I'd
it.
love to know what Alan's constituency wants me to know about how we should have the shared decision-making discussion. But in fact, if a patient comes in to see me, I can't tell them what a toxicity profile would be for a patient who's like that person. I can tell them what a toxicity profile looks like for people in the clinical trial or some population which may or may not be representative of that patient. So all of the value constructs that I mentioned lack some sort of patient-reported outcome, patient experience. They lack that. And I can't tell that woman who's sitting in front of me, your response rate is going to be 14.3% because that was the response rate in the clinical trial. Of course, that's irrelevant for this specific patient for any number of reasons, including the high likelihood that she was not well represented in the clinical trial upon which all the value frameworks are based.
Therein lies the challenge of some of what we're trying to do is the information we have on which to base some of these value decisions now are not reflective in many ways of the individual patient sitting in front of you. So I'm not suggesting in any way we've got that problem solved. What I'm suggesting is that's the problem we should try to be solving. And I think what we can do right now is have that conversation and say, all right, and you probably do this, and many oncologists do, but it's not systematized or scalable in a way that makes sense, that can be repeated and reimbursed. But talking about what is it that's important, what are you concerned about when it comes to safety? Well, I don't know what you mean by safety. Well, let me talk you through some of the, having that conversation to understand what's important to that patient about, what do we mean when we say progression-free survival? What do we mean when it says the tumor shrinks? Giving them that context for what these different what we know about efficacy and safety now, and having that conversation about what's important. Say, here's what we know. We know from clinical trial data that you're likely to have this side effect. I don't know if it's going to be the same for you, just be honest, but this is the best option for you, it looks like, or here's the 3 options that based on what you said, here's some of the trade-offs, and then somewhere in there the cost conversation. Not every patient is going to want that kind of engagement or conversation, but I think more and more we're going to have it as long as we continue down this path of shifting more and more of the cost onto the consumer, and particularly the patient, and particularly those that are really, like I said, the patients that we serve, making serious trade-offs in their lives around their medical care versus their ability, the day-to-day cost of living.
Yeah, I would just say, listening to this and hearing what you just said, going back to some of your comments as well, Dr. Kolodziej, is that enhancement of that patient discussion, from what I understand, is actually the goal of the NCCN evidence blocks, right? To talk about a specific value scoring tool. So sort of set aside the robustness or lack thereof of the inputs to the evidence blocks themselves, and think about what is the intent. There's a big difference between that and ICER and what ICER is looking to try and accomplish. ICER's customer, in my opinion, is you as the payer.
Agree. I totally agree. So I think the ASCO value framework and the NCCN evidence blocks are built towards a shared decision-making perspective. Right. The drug advocates and ICER are about how much your drug should cost at the time of release, given quality-adjusted life years or whatever metric you wish to use.
Really focus on
it's very different. It's very different.
Let's not forget the fact that, and I agree with all this discussion, there have been a lot of good strides made already in oncology, especially, and I'm not just saying this bias on the community side. If we look at the oncology medical home that a number of individuals have been involved with, that Mike is rolling out all over the place, literally it is you're talking about measuring quality and value. You're talking about the fact that we have 9 practices in this country which were accredited as an oncology medical home. That required them to do things like be open or available 24/7 so that a patient doesn't go to the hospital for hydration on a weekend. The patient goes literally into the clinic. It has required them to rethink, and I'm not saying that it's perfect now, it's all there, but there have been a lot of strides. So I just want to make the point, Bruce, that I think a lot of, it's not perfect, But a lot of work has been done, and a lot of work of even looking at things like the patient experience. Certainly, Alan has his tool that they've looked at, which is different from the COA tool, which has been administered now over 70,000 times. That has forced oncologists to think about even the things they normally don't think about, like how long am I keeping the patient waiting? What does the patient think about me? That can lead to the back end as well as when we talk about the treatment. So I think let's not ignore the fact that there's a lot that's been done already.